Hi, it's Dr. Centeno, and thanks so much for watching today. We're going to talk about type 1B CCI, or damage to the anterior ligaments at C0, C1. So just some housekeeping before I get going. I will be sailing from April 24th to June 2nd. I'll also be releasing one video a week on Facebook and YouTube during that time. Now, obviously, I won't be doing my usual Facebook Lives twice a week, so these won't have a live Q&A. They'll just get released one a week. They've been all pre-recorded. But I will periodically jump on a Facebook Live on the European time zone to keep up with some QA sessions. So I'm not quite sure where that's going to land with regard to time in the US, but just to give you an FYI what I'm doing. So as you know, the Centeno classification for CCI is that a type 1 is or involves C0, C1, and we'll be talking today about type 1B. So type 1A is instability and flexion, type 1C is instability and sliding of the skull, and type 1D is instability and rotation. And type 1B, which is what we'll be talking about today, is instability in extension. So type 1B, angular instability and extension. So you probably know that there's this thing called a clivoaxial angle, and that's basically the angle between the skull and the dens of C2. So this is C1, this is C2, and this is the skull, or C0. Now, when you come into extension, the ligaments up front here are what stop your head or your skull from banging into the back of C1. Now, if those ligaments get injured or become lax, that can lead to instability, and that's this type 1 angular instability and extension. So what ligaments could be involved here? So these are the anterior ligaments. Now, realize that your C0, C1 joints live about here. And so your axis of rotation for the skull is going to be approximately where that line is. So anything anterior to that would play a role in that type of instability if that thing connects C1 to the skull itself. So C1 here to the skull, or C0. So that's going to be ligaments like the SAAOL, the AAOM, even less so the apical ligament or parts of the cruciate ligament. So all of these anterior ligaments between the atlas, C1, and the skull. Now, that includes a ligament that has only recently been talked about, as far as recently being 2019, and that is this lateral AO oblique ligament. So realize that we're also talking about that ligament here as well. That one is hard to show on a sagittal. Here we're looking from the front. And just to show you here, this would be where C1 is, this is C0, or the skull, this is C2. So that's where that ligament lives in yellow. Now, how is this type of CCI diagnosed? Well, upright MRI in flexion and extension can be very, very helpful. In this case, we can measure a clivoaxial angle here and here and look at if that angle gets too big. And that angle is going to be here. Again, a key to understanding this is this clivoaxial angle. And just so everyone's clear on what that is, again, I'm just going to review it real quickly. The skull is up here and C2 is down here. So it's this angle between the skull and C2, which indicates how far forward or backwards the skull tilts when you look down or look up. And this is actually from an upcoming paper that I'm publishing on all these different things, including the PICL procedure. But here I took all of the data from lots of different studies and graphed the normals of what they considered with regard to this clivoaxial angle and in different conditions. So basically in neutral, we see that the headache population had clivoaxial angle of 152. If we look at that control group, it's 160. In neutral, 161. In neutral for this study, 162. In neutral for this study, 157. So really anything over 160 clivoaxial angle in neutral would be considered abnormal. And then the only one of these that really looked at flexion extension is this small study, so we probably won't go there. But gives us an idea of how far posteriorly rotated that skull should be. So if you look at that, I kind of pegged it as 160 to 162. If you go in the middle of that, 161 in neutral would be consistent with type 1B CCI, where the skull is falling too far backwards. Now in DMX, or cervical flexion extension views, you're going to see excessive posterior rotation of the skull or opening of the area between the atlas and that basion. But getting CXA measurements from these is going to be more challenging. Now, one of the things you can see on DMX, which is certainly a hint that this may be going on, or type 1B CCI may be going on, is that the skull often hits the back of the C1 atlas area. So remember, again, this is the skull up here, the way I have it drawn. So that's also called C0. And then this is C1. And so you can see the skull hits the back of C1 here. I'll draw a little explosion there so you can see what I'm talking about. So what kind of injection do you need? Well, this is going to be that level 5 injection where you have to come from the front to get those ligaments. So that's a PICL approach. So in summary, type 1B CCI is when the skull falls too far back with cervical extension. This can be detected on both upright MRI with flexion extension, and a little less so in DMX, although we can get some clues from DMX that that could be happening. Generally, we need the upright flexion extension MRI to accurately measure that CXA. And treatment requires reaching the anterior ligaments between the skull and C1 from the front using a PICL approach. So thanks so much for watching, and